Hello and a very warm welcome to the European Antibiotic Awareness Day. Hopefully no global internet outage today. My name is Martina Marx, I'm a health journalist from Austria and I will be your guide through the next 2 hours. Our motto today is From Resistance to Resilience. Healthcare workers leading the change, because healthcare workers are on the forefront when it comes to dealing with and fighting against antimicrobial resistance. They face the daily challenge of treating patients with infections that are increasingly difficult to treat, often with limited therapeutic options and higher risks of complications and mortality. For healthcare workers, as you well know, the whole health system, this means an additional burden in terms of time they need to spend containing an outbreak, treating the patients, and in terms of financial resources. Also, there is an emotional cost. I was angry that this outbreak was happening. You will later hear Paula Ramirez, an intensive care doctor from Spain, say. Together with her colleagues, she had to fight the Candida auris outbreak. The emotional cost for the patients as well as the healthcare workers was severe. And right now, new data collected and analyzed by the ECDC shows us that the situation with antimicrobial resistance is getting worse, not better. And new bacterial strains are emerging that are resistant to several antibiotics at the same time. Just one example for the situation we're in right now. Bear with me. The EU total consumption of antibiotics was in 2024 2% higher compared to 2019, thus indicating a setback from the 20% target reduction for the EU set by 2030. So, yes, there has been slow progress and there are setbacks. But there are examples that show us that these problems can be tackled and resolved. There are actions and routines teams of healthcare workers can adopt to minimize the risk of infections for themselves and their patients or outbreaks. And by doing so, they can save lives. And today you will hear from experts from all around Europe. But now, before we get into our topic, a few house rules. Please ask your questions and ask a lot of them through our Q&A panel on the right side of your screen. The questions will be directed to speakers during the question and answer session. You have the option to also have subtitles in multiple languages. You have a button on your low right corner, but beware they may not work for the 2 videos we are showing you. Please note that the whole digital event is recorded and will be later shared on the EAAD page. Enough of the housekeeping, let's start with the program. First up, we travel to Athens, only via video though. Aristoteles Papadimitriou will show us what facing antimicrobial resistance means from the perspective of an IPC nurse within the Greek healthcare system. Please start the video.
Με λένε Αριστοτέλη Παπαδημητρίου, είμαι νοσηλευτής επιτήρησης λοιμόξεων και δουλεύω στο ογκολογικό νοσοκομείο Άγιος Σάββας στην Αθήνα. Η μικροβιακή αντοχή είναι ένα φυσιολογικό φαινόμενο. Οι μικροοργανισμοί, όταν δέχονται την πίεση ενός αντιβιωτικού στα πλαίσια μιας θεραπείας, προσαρμόζονται, αντιδρούν, αρχίζουν και αμήνονται. Οπότε πρακτικά το αντιβιωτικό χάνει τη δραστικότητά του. Αυτό σημαίνει ότι θα πρέπει να χρησιμοποιήσουμε ένα άλλο αντιβιωτικό από μια άλλη κατηγορία, πιο ισχυρό, όπου και εκεί βέβαια έχουμε πάλι το ίδιο φαινόμενο. Και πλέον έχουμε φτάσει στις μέρες μας να έχουμε και λοιμώξεις από μικροοργανισμούς, οι οποίοι δεν έχουν σχεδόν καμία ευαισθησία σε κανένα αντιβιωτικό. Αυτό το οπλοστάσιο που είχαμε ενάντια στις λοιμώξεις και τους μικροοργανισμούς εξαντλείται. Στο νοσοκομείο μου συναντάμε κυρίως γκράμμα αρνητικά πολυανθεκτικά παθογόνα, κλεμψιέλα, ψευδομονάδα, ασυνετομπάκτερ. Βλέπουμε όλο ένα και περισσότερο εξαιρετικά ανθεκτικά ή και πολυανθεκτικά στελέχη κλεμψιέλας. Και βέβαια ο νέος παίκτης είναι η Candida auris, ένας μύκητας που θα μπορούσαμε να πούμε ότι είναι η εξέλιξη της μικροβιακής αντοχής. Ένας μύκητας που γνωρίζουμε ελάχιστα για αυτόν, πρακτικά ανακαλύφθηκε το 2009. Παρ' όλα αυτά βλέπουμε ότι διασπείρεται ταχύτατα, έχει αντοχές σε φάρμακα που χρησιμοποιούμε για τη θεραπεία των μυκητιάσεων και το μεγάλο πρόβλημα με αυτόν τον μύκητα είναι ότι διασπείρεται πάρα πολύ γρήγορα, κυρίως μέσα από τα χέρια των επαγγελματιών υγείας αλλά και μέσα από το νοσοκομιακό περιβάλλον, γιατί εμφανίζει πολλές διαφορές σε σχέση με τις μυκητικές λοιμώξεις που αντιμετωπίζαμε μέχρι τώρα. Οι νοσοκομιακές λοιμώξεις και η μικροβιακή αντοχή έχουν κόστος. Έχουν κόστος καταρχάς οικονομικό για το σύστημα υγείας, άμεσο κόστος, γιατί μια νοσοκομιακή λοίμωξη, ιδιαίτερα από ένα πολυανθεκτικό παθογόνο, θα απαιτήσει πόρους. Θα χρειαστεί ο άρρωστος να μείνει παραπάνω στο νοσοκομείο, άρα θα στερήσει αυτό το νοσοκομιακό κρεβάτι από έναν άλλο ασθενή. Πέρα όμως από το άμεσο και έμεσο οικονομικό κόστος, έχει και συναισθηματικό κόστος και για τον ίδιο τον ασθενή, αλλά και για τους επαγγελματίες υγείας. Κανένας επαγγελματίας υγείας, γιατρός ή νοσηλευτής, δεν θέλει να πάει καλά ο άρρωστός του. Ιδιαίτερα σε ένα ογκολογικό νοσοκομείο, όπου η εξουθένωση λόγω της επαφής με τους ογκολογικούς ασθενείς είναι ένα πάρα πολύ συχνό φαινόμενο, όταν προσθεθεί και το ζήτημα της μικροβιακής αντοχής και των πολυανθεκτικών παθογόνων, τότε για τους επαγγελματίες υγείας αυτό περιπλέκει τα πράγματα ακόμα περισσότερο, κάνει ακόμα πιο δύσκολη τη δουλειά μας. Και είχαμε και ένα περιστατικό στη μονάδα εντατικής θεραπείας. Η κοπέλα αυτή ήταν 28 χρονών. Έκανε όμως μια σοβαρή επιπλοκή στην επέμβαση και εισήχθη για νοσηλεία στην μονάδα εντατικής θεραπείας του νοσοκομείου μου. Έμεινε για μήνες. Εμφάνιζε το ένα πολυανθεκτικό μετά το άλλο. Εμφάνιζε σηπτικά επεισόδια το ένα μετά το άλλο. Παρ' όλα αυτά ανέκαμψε, αποσωληνώθηκε, μπορούσαμε και της μιλάγαμε. Ήταν μια νέα κοπέλα. Δυστυχώς όμως τα πολυανθεκτικά δεν της επέτρεψαν να φύγει. Έκανε σηπτικά επεισόδια, σώθηκε, αλλά ένα από αυτά τα σηπτικά επεισόδια ήταν και το μοιραίο. Και θυμάμαι ότι πέθανε πέρσι το Δεκέμβριο, κοντά στα Χριστούγεννα. Ήτανε πολύ λυπηρό και ήταν μια 28χρονη κοπέλα που απλά ήθελε να κάνει παιδί. Αυτό που θέλουμε είναι να αλλάξει η συμπεριφορά των επαγγελματιών υγείας, είτε μιλάμε για την υγιεινή των χεριών, είτε μιλάμε για τη χρήση των αντιβιωτικών. Οι νοσοκομιακές λοιμώξεις σε πολύ μεγάλο βαθμό μπορούν να προληφθούν, να αποτραπούν εντελώς είναι πολύ δύσκολο, αλλά μπορούμε να προλάβουμε πάνω από το 50% των νοσοκομιακών λοιμώξεων και τα κύρια μέτρα πρόληψης είναι πολύ απλά. Είναι η υγιεινή των χεριών, είναι η εφαρμογή των μέτρων ατομικής προστασίας, καλή καθαριότητα στους χώρους του νοσοκομείου, σωστή διαχείριση των αντιβιωτικών μας. Όλα αυτά, αν εφαρμόζονται μαζί, μακροπρόθεσμα μπορούν να αποδώσουν. Μπορούμε να κάνουμε μεγάλες, πολύ δύσκολες επεμβάσεις, για παράδειγμα πολλαπλές μεταμοσχεύσεις οργάνων στον ίδιο ασθενή και τα κάνουμε όλα τέλεια. Το πρόβλημα είναι ότι δεν μπορούμε πολλές φορές να εφαρμόσουμε απλά πράγματα, όπως είναι η υγιεινή των χεριών, η τήρηση βασικών κανόνων αντισηψίας και η τήρηση των μέτρων ατομικής προστασίας. Δεν είναι αγώνας δρόμου, είναι μαραθώνιος. Για παράδειγμα, αυτή την περίοδο έχουμε μια πολύ μεγάλη χειρουργική κλινική, στην οποία και αυξήθηκε το ποσοστό συμμόρφωσης στην υγιεινή των χεριών και ταυτόχρονα σήμερα είναι 337 μέρες με μηδενική επίπτωση από βακτηριαιμίες που να συνδέονται με την κεντρική γραμμή. Άλλη μια επιτυχία ήταν οι νηπτήρες στη ΜΕΘ. Μπορεί να ακούγεται λίγο οξύμορο, γιατί οι νηπτήρες έχουν συνδεθεί με την υγιεινή των χεριών και έτσι ακριβώς είναι. Αλλά υπάρχουν περιπτώσεις μέσα στο νοσοκομείο που οι ίδιοι οι νηπτήρες μπορεί να είναι πηγή διασποράς πολυανθεκτικών παθογόνων. Έτσι λοιπόν και στη μονάδα εντατικής θεραπείας είδαμε σε μια περίοδο αύξηση, μια περίεργη αύξηση της επίπτωσης από ένα πολυανθεκτικό παθογόνο, την ψευδομονάδα. Σε συνεργασία με το εργαστήριο του νοσοκομείου, με το μικροβιολογικό εργαστήριο, βρήκαμε ότι η πηγή ήταν 2 νηπτήρες που ήταν κοντά στις κλίνες των ασθενών. Όταν σταμάτησε η χρήση αυτών των νηπτήρων και σταδιακά καταφέραμε να τους απομακρύνουμε κιόλας από τα συγκεκριμένα σημεία, είδαμε την επίπτωση να πέφτει. Αυτές είναι μικρές νίκες που μας κάνουν κιόλας και μένουμε σε όλη αυτή την προσπάθεια έναντι της μικροβιακής αντοχής. Και είναι και ένας από τους λόγους που πρέπει να δράσουμε πλέον και πρέπει να δράσουμε άμεσα, αντί να αντιδρούμε, γιατί αυτό κάνουμε μέχρι τώρα σε σχέση με τα πολυανθεκτικά παθογόνα, απλά αντιδρούμε αντί να δρούμε, έτσι ώστε να βοηθήσουμε και τους ασθενείς μας, αλλά και τους εαυτούς μας ως επαγγελματίες υγείας. Άλλωστε να μην ξεχνάμε ότι στη θέση των ασθενών που διαχειριζόμαστε, που νοσηλεύουμε σήμερα, αύριο μπορεί να είναι ένας δικός μας άνθρωπος ή ακόμα και εμείς οι ίδιοι.
Move on to our first keynote speaker. Before we do that, I will advise you that you can use automatic captions in all EU and EEA languages. You can do so by clicking the CC button at the bottom of the video player. But now it's time to welcome Mr. Péter Álmos from the Standing Committee of the European Doctors. He will talk about supporting doctors to overcome barriers in IPC and antimicrobial stewardship practices. The floor is yours, Dr. Álmos.
Thank you very much. Dear colleagues, dear audience, thank you for the possibility to speak here on behalf of CPME. Our organization has 28 members, representing 1.7 million doctors in Europe. We are aware of the pivotal role that doctors have in the prudent use of antimicrobials in IPC and stewardship teams. CPME, therefore, conducted a survey on antimicrobial stewardship and public awareness among its members back in 2020 that showed the actions to manage AMR at national level remain highly inconsistent and uncoordinated. There is an enormous potential in the member states, which can be better exploited through effective cooperation. We think there is a role for the EU to play in coordinating national efforts on combating AMR. The majority of surveyed countries have implemented either national, local, or both types of AMR stewardship programs. I would like to talk about 3 good examples. In the Netherlands, there is an extended stewardship program in primary and secondary care with AMR being monitored and a yearly report published as NEFMAP. There are practice guides and guidelines for antimicrobial stewardship provided, for example, by the Dutch Working Party on Antibiotic Policy, called SWAB, already in 2016. In Germany, there is a revised national guideline on antimicrobial stewardship in hospitals. It's accompanied by an active training program for hospital doctors and pharmacists. Some regions even have intersectional programs for local, regional practice guidelines to contain bacterial resistance. It's important to note about half of the hospitals have antimicrobial prescribing task forces, but they often restricted in scope due to personnel shortages or lack of funds for salaries. At CPME, we think that human workforce crisis in healthcare is one important issue to consider when talking about AMR. Third good example is the Slovenian one, where the government adopted a national strategy and action plan in 2019 to address AMR. Since 2011, programs aimed at containing AMR have been made mandatory in every hospital. The Ministry of Health oversees antimicrobial stewardship activities in hospitals through the intersectional coordinating mechanism for the prudent use of antibiotics. At CPME, we have adopted a policy on AMR in April 2023 that highlighted the importance of stewardship, communication, and prudent use of antimicrobials as important cornerstones. Stewardship interventions at all levels of care, along with other legislative and technical steps, are indispensable to fight the spread of AMR. Actions before, during, and after prescribing are needed to guide prudent use of antibiotics. Stewardship should be preceded by a dedicated effort to prevent infections. And stewardship also involves communication with patients. So doctors need to have sufficient time to reinforce this important aspect of their relationship with patients. Doctors must prioritize the narrow spectrum antibiotics while considering individual patients' needs. A decisive factor in ensuring prudent use of antimicrobials is access to fast and efficient diagnostics. Studies show that by implementing point-of-care testing by doctors, and antibiotic consumption and AMR decreases. This helps in decision making between narrow and broad spectrum antibiotics, obviously. Implementing prescription feedback system at healthcare or doctor level can also be helpful. Prudent and evidence-based use and prescription of antibiotics must be a cardinal role for all doctors. Guidelines and prescribing antibiotics should state that antibiotics should be only prescribed when necessary, and when prescribed, it should be in the dose, the appropriate dose for the infectious disease to be treated, and as short as possible according to prevailing guidelines. Last but not least, we are also calling for this to be strengthened in the ongoing negotiations of the general pharmaceutical legislation. Thank you very much for your attention.
So we have a little shuffle in our schedule. Mr. Radu Botgros is the next one up. He will talk about should I treat, and this is a very good next topic which Mr. Álmos just talked about. Should I treat this patient with antibiotics? Does it matter which one I treat them with? The floor is yours, Mr. Botgros.
Thank you very much, and thanks for to the organizers for inviting me at this very important webinar. Hello, my name is Radu Botgros, and I'm a senior scientific officer at the European Medicines Agency. So in the next 10 minutes, I will talk to you about this paradigmatic question, whether I should indeed treat a patient in front of me with antibiotics. I don't know if I can have my first slide. You see already from this starting slide, if you look at this image of the doctor and the patient, you see that actually you can think about it of not being just a medical checkup. It is actually the moment when a critical decision is made that affects everyone. Should this doctor treat this particular patient with an antibiotic? This is something that we all need to reflect upon as healthcare professionals. Next slide, please. And we need to remind ourselves that antibiotics are some of the most powerful tools we have in modern medicine. But every time a doctor writes a prescription, actually the decision has consequences far beyond just the one patient for which the prescription is written. We know that we are facing this global crisis of antimicrobial resistance, and that the resistance rates are unfortunately climbing steadily every year. And you can see on the map on the right-hand side of my slide that, of course, this is happening globally. So the fundamental question that we need to ask ourselves is not just which medicine, which drug, which antibiotics I should be using, but actually, should this patient's receive, to remind ourselves that every time we use these drugs inappropriately, we accelerate actually the crisis. And every time we use them wisely, on the contrary, we save them for the future. Next slide, please. Yes. So you see on this slide, I try to depict the pillars of decision making. In other words, how does a doctor decide? Actually, it's not random. We rely on what we call judicious prescribing. So we need to think about the evidence first. So we should only prescribe when a bacterial infection is probable. We need to remind ourselves, but also to the patient, that antibiotics kill bacteria, not viruses, like, for instance, the common cold and other viruses. We should also follow the rules. We must stick strictly to clinical guidelines at the very least. Sometimes also it's useful to look into the approved product information that is being vetted by the regulator, because it's important to ensure that the right dose and duration are correctly prescribed. And last but not least, but quite important, maybe even more important than what I said until now, is that the doctor should resist pressure. It's very hard, but we must avoid prescribing just because the patient or the parent of a child is pressurizing us. I think in this particular cases, education is probably much better than the prescription. So these are things we need to think about. Next slide. You see here the classical diagnostic steps. We use normally a 3-step process to have a good understanding and reassurance that we're talking about the bacterial infection. There is first the clinical assessment. Essentially, we look at the history of the patient, we examine the patient, then we do some lab confirmation. If we are in a hospital, we can do blood cultures, we can do some markers like CRP to confirm or to support whether it's a bacterial infection. And only then do we decide whether we need an antibiotic and which antibiotic it should be. The challenge here, the important challenge, is in outpatients. Essentially, we often lack rapid tests that can tell the difference between a virus and bacteria instantly at the doctor's office, which makes clinical judgment extremely important. So I can't emphasize this too much, really. Next slide, please. Of course, this is, it's not only about the doctor, so it's also about the patient. So the patient has a very important role. And actually, the medical consult is not a transaction. It's actually a partnership. So patients should feel empowered to understand why antibiotics are or are not needed. And actually, understanding that most respiratory infections are viral helps lower the expectations for them being given antibiotics, which may be unnecessary. There are a couple of important points, some of which are listed here. So essentially, for the patient, if you are prescribed an antibiotic, take them exactly as directed. And keep in mind that incomplete courses can fuel resistance. Then the other important thing is don't self-medicate. So in other words, never use leftover antibiotics or buy them online without a doctor's help. Because this bypasses a number of safety checks, and in the interest of time, I won't dwell into that, but that's very important. And also, when it comes to disposing the pills, the old pills that you have, don't throw them in the trash or in the toilet. I think it's important that you use pharmacy take-back programs or something similar to prevent environmental pollution.
Seems we have a few connection problems with Mr. Botgros. I don't know if we're trying to
Still hear me, because okay. It says right. So I was you lost me at some point. I don't know when.
I think it was after the self-medicate and don't throw the antibiotics in the trash.
Okay, that's very good, because actually this is. Can I have the next slide then? Right. So here it's what's important is you see here on the left and on the right hand side a new versus old antibiotics. So in other words, what should the doctor prescribe? Here, I think it's important for the doctor to remind him or herself that new isn't always better. There is this common misconception that newer drugs are better, but actually our old established antibiotics are our first line of defense. And this is something we need to remember. It's the old that guards drugs like penicillin, for instance, have decades of safety data. They're affordable. They still work for most common infections. So they should be our default choice. And the new recruits, the new antibiotics, we need to remind ourselves they're incredibly precious because we have very few new ones entering the market at present, unfortunately. Next slide, please. Here you can see the regulatory system is also at work. Authorities like my own, the European Medicines Agency, but also physicians are working in the background, monitoring safety, updating product labels, and tracking resistance globally, like throughout the world, but in Europe, it's the ECDC doing that. And also, we need physicians to be champions of stewardship, educating both colleagues, their own colleagues, doctors of other specialties, and leading by example. These are very important things. Next slide, please. On this particular slide, you see that the role of physician as champions of stewardship. I won't be dwelling on that in the interest of time. Next slide. Here you see, actually, this is probably one of the most important takeaway messages. I like to call it the 4 R's. So responsible antibiotic use is about these 4 R's, which are essentially the right antibiotic, the right dose, the right duration, and the right patient. So these are to be kept in mind, because it's not enough to just pick a drug. We must integrate diagnostics, education, and stewardship into one strategy. This is very, very important again. Next slide, please. And I think I've come to my last one. Actually, this is something I like to say whenever I talk about this topic. It's not only which antibiotic we choose, but how and when we use it that will determine our success against antimicrobial resistance. Every judicious decision helps preserve these life-saving medicines for the future, and I cannot stress less the fact that we need to work together to make it happen, because if we lose these armamentarium, we will be back more than 100 years before the antibiotics were discovered. So, before penicillin, before Pasteur, where then, things that we take for granted nowadays, like, a simple surgery or even, oncologic treatment will become impossible. So this is not a silent pandemic. This is something that unfortunately is growing, and the fire is burning under our seats. Please keep all of this in mind. It's very, very important. I'll stop here. Thank you very much.
Thank you very much, Radu. That was very insightful. Next on our list is Massar Dabbous. She's now here, and she is from the Center of Behavioral Change from the University College in London. Hello. She will talk about behavioral insights for strengthening infection prevention and control, practical lessons from and for healthcare workers. The floor is yours.
Thank you so much. Hello, everyone. Good afternoon. Yes, UK at University College London. I work specifically as well across the EPCSRC Digital Health Hub for Antimicrobial Resistance, where we collaborate on interdisciplinary projects with healthcare professionals and bring in behavioral insights on how to engage with technologies such as new developments of diagnostics, etc. So today I'll talk a bit about how we can bring in those behavioral insights to developing interventions for strengthening infection prevention control. Next slide, please. So just to begin, as why we should think about behavior change when it comes to infection prevention and control, I think some of the previous speakers touched upon some of the elements of human behavior, but we do know that there are countless efforts to disseminate knowledge and evidence about the best practices for infection control, such as through guidelines, education, training initiatives. But despite all this, we have experienced, I'm sure we all know, that there are gaps between what is best practice and what's actually happening in practice. So if we take hand hygiene as just one example, there's overwhelming evidence of how important hand hygiene is to help decrease the spread of infection. However, we also do know that there is evidence that globally compliance with hand hygiene guidelines is suboptimal. And this is also the case for other actions involved that are important in infection prevention and control, such as using personal protective equipment, cleaning and disinfecting surfaces, proper waste disposal, uptake of vaccinations. And all of these, if you think about them, are element of behavior. So it's a bit more thinking about more than just giving guidelines. Next slide, please. And then implementing change is what's important with implementing change is that it always requires us to do something differently. So this is also the case with antimicrobial stewardship. It also involves other elements of human behavior, such as the judicious use, proper antimicrobial prescribing, as well as patients, for example, finishing their treatment. So it all requires behavior change, such as adopting a new practice, doing more of a certain practice, doing less of a certain practice, such as reducing antibiotic prescribing where it's not necessary, of course, or stopping or discontinuing a practice. Next slide, please. However, within infection prevention control and antimicrobial stewardship, there are a lot of interventions that have been based on assumptions about human behavior. We like to call that what we call it seemed like a good idea at the time principle. So this kind of involves interventions based on hunches without really a rationale, perhaps using an intervention that has worked elsewhere and applying it to a context, or just handing out guidelines, or we will just educate and train, or throwing everything and seeing what works. Sometimes in this scenario, the intervention might work. However, it would work if the intervention is targeting the right type of behavioral influence. And in this case, it becomes an expensive version of trial and error. And this is where behavioral insights is important. Next slide, please. So we use behavioral science in the sense to be able to bridge that gap between evidence and practice, to have that rationale. Behavioral science offers theories, frameworks, methods of understanding what drives a behavior, and then that way we can use it to design interventions to see how we can effectively change it. It is a stepwise approach, and we know behavior is complex, of what I just mentioned earlier. So we'd want to simplify it into small steps in a stepwise approach. We usually like to think of this analogy as like when you're going to see your GP. A GP would examine the problem. He or she would make a formulation or a diagnosis, and then prescribe a treatment for that specific diagnosis. And this is what we also think about when we conduct a behavioral intervention based on our behavioral theories. Next slide, please. So in the first step that I'll go through this, and I'll use hand hygiene as an example. First of all, what tends to happen is that we usually rush to outcomes where we just want to reduce infections. However, reducing infection isn't necessarily a behavior. What we would want to think of what is involved in this behaviors. There are different elements, such as hand hygiene practices, such as using appropriate use of PPE equipment, etc. So we'd break down these numerous discrete behaviors and would want to target them individually to be able to influence that outcome. Additionally, we want to also be very specific and think about to change a certain behavior, who needs to do what, where, differently, and with whom. So for example, if we want to improve nurse hand hygiene compliance, that in its own, it's very vague. We think about what do we want these nursing staff to do and where. For example, the context differs if we're in the ICU versus another ward or versus primary care, etc. That way, the choice of intervention will be very different for each when we are specific. And you really do find that the implementation of our processes differs when you design interventions when we're very specific. And also to think about when do we want these behaviors to be changing. Next slide, please. And then this allows us to move then to our second step, which what we call is diagnosing a behavior. And here we think about why is behavior the way it is, what helps and what gets in the way. And this is where we use theory to understand those barriers and enablers to influencing a behavior. And one of those theories that's commonly used is what we call the capability, opportunity, and motivation COM-B model, which gives us a lens through looking at this complicated problem and gives us explicit statements of what we're asking to understand those influences of behavior. And within this theory, we're able to see that the interaction between these three conditions all work in a system, and when they're all present, they will influence behavior. So for example, to increase behavior, we would want someone to encourage them to perform the behavior and make it easier to do so through capability and opportunity, and then compared to not doing that behavior, so providing that motivation to do it. So for capability, we'd want to look at influences such as the skills people have. Would they be both physical and psychological, such as remembering to do a process? For motivation, we also think about for motivation, we think about those automatic and reflective elements of motivation. So such as what are the influences within competing priorities, within the role of who we're looking at? Does it fit in their professions? Is it a routine? Is it of concern? And for those opportunities, we think about those physical opportunities in place that influence the behavior, such as the resources, the supplies, as well as social opportunities such as the team dynamics, patient influence, etc. So when thinking about all of these elements, we can again helps us design that intervention for those influences. Next slide, please. And there are several studies that have used this theory across hand hygiene to look at the influences of hand hygiene behavior. And as you can see here, a lot of them are in different contexts with different actors. And I'm going to just summarize just a few of these influences that have been found at these studies in the next slide, please. Some of these key findings that have influenced hand hygiene behavior, for example, within the capability element, such as this looks at those cognitive overloads or that poor procedural memory. So barriers to capability includes forgetting the steps of hand hygiene routine during busy shifts. So that's one influence to think about that influences compliance to this behavior. For motivation, it's thinking about the perceived risk that a person would have about transmission. So barrier will thinking that you don't have that strong risk of transmission. And then for those opportunities is linking those the barrier of not having enough supplies, not having enough alcohol gel, PPE equipment, gloves. All of these factors together influence that one behavior of hand hygiene behaviors. So thinking about them all will help us understand what kind of intervention we would want to address to be able to implement a successful intervention, which I will go through in the next slide briefly. So to develop an intervention strategy to tackle the influences, those barriers and enablers to hand hygiene, we would then also use a framework here. This is the behavior change wheel, which synthesizes 19 different frameworks with the theory that we just discussed at the center to be able to match the choice of intervention strategies to target those influences. And what we try to do for a successful implementation using this behavioral strategy is that we try to target more than one influence with more than one intervention strategy as well. So we would move beyond just an intervention of providing training or providing education. And I'll just give an example of this with a study in my final slide. So, for example, an effective hand hygiene behavior change that was implemented across UK healthcare workers in London. This was a randomized control trial that was across 16 different trusts in the UK. And the intervention involved 4 weeks of observing hand hygiene behavior among staff, and then providing feedback on the hand hygiene practices and personalized action planning through goal setting to allow changes in that behavior. So this was beyond just increasing knowledge and increasing in education, but targeting those specific practices that were observed through these personalized individual plans. And this led to moderate, sustained improvement in hand hygiene compliance. And then there are similar studies, just to finally end and bring it back to antimicrobial stewardship. So this behavior change approach has also been applied to antimicrobial stewardship and being able to target those antimicrobial prescribing practices as well, to seeing what influences different prescribing practices and targeting effective behavior change. I think that's my final slide. Thank you very much.
Thank you very much, Massar. Now it's time for our first panel round and questions from you listening at home or at work. So I will remind you, please ask your questions within the chat. They will come up to me on a different screen. And I start with one question of my own. We heard from Mr. Papadimitriou from the first video we saw before from Greece that he said we want the behavior of health professionals to change in terms of hand hygiene as well as antibiotic use. This sounds reasonable. We have heard it from you three as well. But how do we achieve this in reality? And could it be that measures that work in one hospital are not as successful in another? I think, Massar, I will start with you.
Yes, I think that's very timely to the behavior talk. Again, being very specific about those, what I mentioned about the context of what we're applying is really important, because it does differ when it's working within if you're working in an acute setting or versus a secondary primary community care setting, and those influences in the different settings really make a difference. And as well as thinking about who are performing these behaviors make a difference, versus if we're talking about nurses being on very busy shifts versus different community healthcare professionals, that also differs. But using a stepwise theory-based framework approach that I just highlighted allows us to be able to measure the different behaviors behaviors and that behavior of change. And that allows us to be able to, one, measure the impact and see the effect of our change. And that way we can replicate and then scale up the different interventions and see how we would need to accommodate across different contexts.
Mm-hmm. I think Péter Álmos had a few points on the next question. It's also for Massar if you want to address it later. But how can we promote behavior change in an environment of healthcare workforce shortages and high workload? I mean, I think you pointed out, Péter, that the personnel shortages of the doctors are a real problem in addressing this problem.
Yes, that's a clear issue. So our survey and the experiences from Germany show that even when you have the proper guideline, the proper stewardship notes, and people know what they should do, if they don't have the time or there is not enough financial resources to pay people who work on IPC, so then it's not enough. So that's why we think it should be coordinated on an EU level, and it should be an important point of the pharmaceutical legislation that healthcare, the workforce crisis in healthcare is one component of the problems with AMR. So we think that we have to solve this first, or parallelly with developing guidelines. So it's very important to develop guidelines. It's very important to let the doctors know, but even if they know it, how to behave and which guideline to follow. If there is not enough time, it's going to compromise the fight.
Mm. Massar, do you have a point on that?
Yeah,
on the shortage?
I think just to add as well, I think that's why when we look at the different influences, time is one of them. And this is where when we're designing interventions, we look at the different aspects and we target what we can change. So towards the end, I kind of briefly summarized this wheel that we look at and how we choose our strategies. But when we go to look at these different strategies, these different influences and the different potential strategies we can develop to target them, we also work with the like we co-produce them with our population of interest and stakeholders to be able to identify what's a realistic intervention that we can implement. So whether if resources are unavailable, we can think about, again, there's a criteria to look at what's the likelihood of an intervention to work, what are the challenges, what are the spillovers, what resources do we have, what resources we don't have, and that way we can try to implement one for the context, again, thinking about the specific context of what would be a sustainable intervention. And again, stepwise approach, and that way we can start to build on an intervention in stages once we can kind of grow an intervention.
Radu, in preparing for this event, I was talking to an Austrian specialist in the field of antibiotic and antimicrobial resistance, and he told me that he was surprised to see that when you go to a normal doctor's office, the blood test is not as specific as when you go to a hospital. So normal doctors prescribe probably broadband antibiotics more often than you would do in the hospital. How can you tackle, or how could we tackle this problem?
Thanks very much for the question. I think this is an important point, and indeed, sometimes it's very difficult for patients that go to their general practitioner to get a full bacteriologic diagnostic. We need to also remind ourselves that when you go for a blood culture, the result is not instantaneous in most of the time. So it's really difficult at the time when the doctor makes the consult to rely on an exact bacteriology result. Not to mention that, as I tried to allude into my presentation, the point of care diagnostics, the one that the doctor can use at the in front of the patient in this kind of setting, are unfortunately not there. So this is one of the big challenges, and this is where I think the clinical judgment comes into place. And I think it's very important that the doctor conducts a full clinical exam of the patient, and also takes some time to get the exact history, because sometimes this orients very much the diagnosis, and you feel more empowered to, let's say, not prescribe an antibiotic, or if you do prescribe one, to go into the right direction rather than going as broad as possible to make sure that somewhere some bugs will be covered, which obviously for AMR is not a good idea. So to cut a long story short, I think it's very, very important that we talk to the patient. And speaking about the time, I wanted to interject as to what colleagues were saying, and it's quite clear that also in the general practitioner's office the time is limited. But I think if we want to become successful in fighting AMR, we need to take the time to do something about it. We don't need to rush in and just write something for the sake of doing it. I think this is utterly important. Thank you.
We come now to a question for Peter. It was posted by Ruth Mada. How about the risk for healthcare workers to infect themselves with resistant bacteria?
Thank you. So AMR and nosocomial infections target mainly people whose immune system is somehow compromised. I mean, because just simply a bone fracture can be so you don't have to need an autoimmune disorder or something like that. So mainly sick people. So the people who are most at risk are patients. Obviously, it's a hazardous environment. So we have to also consider protection of ourselves, and this is also goes back again to money and guidelines in countries and in environments where doctors themselves don't have proper protection equipment, then where patients are crowded in a hospital room because there are not enough rooms to separate them. The risk to spread an infection, a nosocomial infection, or to make AMR worse and use more and more antibiotics is even that's even more complicated. So I would say that doctors are themselves working in a hazardous environment, and it's extremely important to provide them with the personal protective equipments, which, as we've seen, for example, in the COVID, was a critical issue. So that's also, again, another thing which the EU has to have an eye on, that the European Union has to have enough equipments, protective equipment to be stored. Also, this is the same with guidelines and everything. So AMR don't respect borders. So if one country develops a very nice guideline and its doctors and nurses are following it, but the neighboring country is not doing that, then it's very difficult to stop spreading the infections. Thank you.
Probably for Massar, Gerard Colleran posted a question: would an EU-wide educational would an EU-wide educational program for all healthcare assistants involved in routine hospital decontamination be worthy of developing and deploying? Does it help for us when other countries have the same education?
I mean, it's not to say that education is completely not an intervention. Of course, that's something that's needed, and especially like what Peter just said. I mean, AMR doesn't the border. There's no border, so there are some elements which will overlap across. I think in this context, from the behavioral lens, it's to understand a bit more what else of the different influences across the different countries that we're representing. But in this sense, when we are thinking about a nationwide or an EU-wide kind of education program, it would be important to involve the stakeholders and the people who this would impact. That way, you can have those different elements and thought process through those co-production, co-design. So, for example, I think there were some comments about nurses and the importance of nurses. So, kind of bringing in all those people would help having a successful education program.
Mm-hmm. Radu, there's a question for you. In some countries, there are shortages of narrow-spectrum antibiotics such as penicillin and amoxicillin. What can be done about access to these antibiotics?
Thanks very much. That's another important point, the point of shortages of narrow-spectrum antibiotics. And, these old antibiotics like penicillin and amoxicillin are indeed those that are being, targeted most, so to say, by shortages, simply because, whenever the autumn comes in and, the respiratory infection rate goes up in most countries in Europe, the number of visits to the GP goes up. Therefore, also the number of prescriptions goes up, and we don't need to get back into the issue of pressurizing the doctor to write prescriptions whenever you come with your child, for instance, which is something that needs a paradigm shift. But whenever the doctor does not have these drugs available, obviously he will go for something with a broader spectrum, which, as I explained, is not a good thing for antimicrobial resistance. So the good news is that we have a centralized mechanism in the European Union to target shortages. Actually, it's the European Medicines Agency, together with with the regulatory network of the European Union, is working together. We have a working party as well as a body in which all these shortages are reported, and then there is coordination. There is tackling the companies that produce those antibiotics, trying to understand what the problems are, how the capacity can go up, and in which time frame. Sometimes, of course, it doesn't totally solve the problem, but for sure is something that is in our attention. And actually, there have been quite some remarkable progresses. We need to remind ourselves that after COVID, after the pandemic ended, there was a big shortage in Europe of amoxicillin and similar, which I think now, with preparedness work, is of much, much less importance.
Mm-hmm. We have two comments from Noel Abila. I will read them, and then we figure out who wants to go first. The first comment was, we also need to address additional practices such as inappropriate glove use that may inadvertently contribute to transmissions of MDROs. And the next comment from her, it is important that nurses are actively involved in antibiotic stewardship, as they are the healthcare professionals who spend the most time with patients. Concerning the glove use, Péter or Massar or Radu, I'm not sure who wants to go first about the comment of the glove use.
Well, I'm in the interest of time, I can say a few words to that. I mean, wearing the adequate equipment, be it mask, be it gloves, and anything else, is something which is very important. It's part of the standard, of the professional standard of the physician. So honestly speaking, I think this is it's a no-go nowadays to just not do it. And obviously, you need to abide by, changing this equipment after each and every patient, washing the hands. We heard how important it is to do so. So, to me, these things are hopefully routine, actually, for most of our colleagues. And whenever there's a situation in which this is not the case, obviously educational programs must be put in place to remind colleagues of the importance of doing all these things. When it comes to the story with the nurses, I mean, this is probably very important in the hospital setting. But frankly speaking, at the GP's office. I'm not sure that this is entirely true, that a nurse, takes more time talking to the patient, but for sure, it's very important that everybody is up to speed with all what needs to be done, and that periodic refreshment of this information is brought over through various, programs by public health authorities and so forth, because we need to recognize, many things are good old things that we learned in medical school, but there are also new information. And there's also new information out there. And, people are very busy. They sometimes don't have the time to put themselves up to date. So we need to contribute to making this happen. I'll stop here. Thank you.
Thank you. While I'm looking at the time, and we have another panel coming up after the next point, I will ask Radu your final question, because you're not here for our concluding round. So in around 1 minute, what are the key aspects? What is the main message you take away from today to help us moving forward?
Well, I think what for me is most important is that we work together, that indeed we coordinate these efforts, that we don't work in silos, and that we keep in the back of our mind that we are working all for the patient. This is very important, these patient-centric activities. We are all in different capacities, working in hospitals, me and myself as regulator, but we all need to work for the patient, and we need to keep in the back of our minds that if, God forbid, we are not successful, in 20 years' time, we will all be suffering tremendously from deaths which are attributable to AMR. So I think I cannot give a more encouraging message to unite forces. And this is not only among ourselves, but also working with patients. Always communicate, always explain, always take the time. This is personally how I would like things to be, and also the message I would like to convey. Thank you very much.
Thank you, Radu. Péter and Massar, we see you at our concluding round later on, and we can make the comment that nurses are essential for any IPC intervention, when we go forward. And next on, we have our second video, and we go, unfortunately, only by video, to Valencia in Spain. Two healthcare workers, Paula Ramirez and Alba Cecilia Ruiz, talk about how they overcame a Candidosoma auris outbreak and how they managed to keep new infections on a bare minimum. Please start the video.
Mi nombre es Paula Ramírez, soy médico especialista en cuidados intensivos, trabajo en la unidad de intensivos del Hospital La Fe, Universitario La Fe.
Mi nombre es Alba Cecilia Ruiz, soy médica microbióloga en el Hospital Universitario Politécnico La Fe.
Es un hospital con 1000 camas de enfermos agudos. Es un hospital que aúna los pacientes más complejos, que disponemos de prácticamente toda la tecnología y tratamientos necesarios para tratar a estos pacientes. Es altísima porque supone una mayor dificultad, un incremento muy notable potencial de la dificultad en acertar el antimicrobiano adecuado. Entonces, esa presión supone que vamos a usar quizás con mayor frecuencia fármacos de muy amplio espectro para evitar errar en la elección. Y sin embargo, puede que en aquel que estamos decidiendo que no usamos un amplio espectro sea precisamente el que tiene una infección por una bacteria o un hongo multiresistente.
Candidosoma auris fue detectada en nuestro hospital por primera vez en abril del 2016 a partir de un paciente ingresado en la unidad de reanimación del departamento de anestesia de nuestro hospital. Las principales preocupaciones y desafíos a los que nos enfrentamos durante el brote es el ver el aumento en el número de pacientes que se colonizaban y se infectaban de una manera muy rápida en nuestras unidades críticas. Entonces, el principal reto que tuvimos fue el poder identificar rápido y de una manera más precisa. Ese fue como nuestro desafío durante los primeros meses del brote. Necesitábamos poder decir en un tiempo muy corto que un paciente estaba colonizado para poder que fuera aislado y para poder empezar a cortar esa cadena de transmisión.
Y la segunda preocupación ya no solo el individuo, era la gestión de las camas, porque los pacientes los debíamos agrupar para poder poner en marcha medidas de control. Había que mover a los pacientes, pero la cuestión es que si el paciente estaba en una cama y yo debía moverle al otro extremo de la UCI para juntarlo con los otros pacientes positivos, la cama que dejaba libre no la podía usar. Debía dejarla en cuarentena, debíamos hacer una limpieza especial, debíamos tomar muestras de superficie y hasta que esas muestras no fueran positivas no podía ingresar un nuevo paciente.
A nivel emocional pues fue impactante porque Candidosima auris, la infección por Candidosima auris afecta a pacientes muy vulnerables, a los pacientes críticos. Entonces son pacientes trasplantados o pacientes que estaban en una situación muy vulnerable, pues teníamos mortalidades muy altas en pacientes de diferentes edades. Entonces, eso de alguna manera asustaba porque no teníamos toda la información en ese momento. La experiencia en muchas partes del mundo era muy limitada y entonces íbamos aprendiendo en muchos casos sobre la marcha, tanto de diagnóstico como también dirá Paula más adelante, de optimización de tratamiento para poder disminuir estas mortalidades.
Fue una experiencia de pesadilla. Había miedo en el ambiente de que fuera el paciente que yo trato el que fuera el siguiente en ser positivo. Y frustración porque no éramos capaces de yugular inicialmente el brote, como comentaba Alba, porque no teníamos todo el conocimiento, porque la identificación tardaba en llegar, porque no estaba aún depurada, porque no utilizábamos los productos de desinfección adecuados, porque no todo el mundo estaba aún convencido de la gravedad de la situación. Me enfadaba que estuviera este brote en marcha. Sí que, afortunadamente, con ese trabajo multidisciplinar y con todo lo que hemos aprendido y con ensayo-error, ahora mismo estamos hasta cierto punto satisfechos de tener al monstruo hasta cierto punto controlado, no totalmente, porque no debemos pensar nunca que está totalmente controlado, porque puede estar en el último esquina y reaparecer. Formación, mucha formación a todas las personas implicadas en las medidas básicas de control de cualquier tipo de brote, fundamentalmente la higiene de manos, la cohortización de los pacientes afectos. Y después hubo aspectos importantes, esos reservorios que íbamos encontrando de Candida auris, por ejemplo, los manguitos de la toma de tensión. Los manguitos de la toma de tensión no eran desechables, se limpiaban, desinfectaban entre paciente y paciente, pero tienen unos velcros y esos velcros era imposible limpiarlos. Nos dimos cuenta, tomando muestras de nuevo, que el 26% de estos manguitos de toma de tensión en la UCI estaban colonizados, contaminados. Así que dejamos de usar estos y empezamos a usar manguitos desechables de paciente en paciente. El ecógrafo, encontramos que el ecógrafo era un problema, que hubo muestras positivas. El sumidero del agua de la diálisis también fue positivo en alguna ocasión y esto supuso que hace falta esa búsqueda ambiental continua y un cambio en la forma de limpieza, porque estábamos utilizando amonios cuaternarios y los amonios cuaternarios, en el caso de Candidocima auris, sobre todo si está en forma de biopelícula, no son eficaces. Así que tuvimos que volver a la lejía. La lejía había sido eliminada de nuestro centro por organismos superiores por los problemas que podía dar a los trabajadores de la limpieza. Pero la reintroducción de la lejía, tanto en suelos como en superficies, fue lo que finalmente logró ayudarnos realmente al control del brote. Para controlar las próximas avenidas de Candidocima auris u otros microorganismos multiresistentes, debemos reforzar el sistema de prevención. el sistema de prevención a la hora de identificación de los pacientes en riesgo y fundamentalmente aquellos que fueron positivos en algún momento, porque sabemos que pueden tardar meses en librarse de estos microorganismos multiresistentes. Pero lo fundamental sería mantener las medidas básicas de control de la infección nosocomial. Y la medida más importante es el lavado de manos. Y seguimos fallando. Fallamos nosotros y falla prácticamente todo el mundo. No alcanzamos los porcentajes necesarios de un correcto lavado de manos. No somos totalmente conscientes de lo importante que es esto. Antes de atender al paciente, después de atender al paciente. Protocolos de limpieza cuantas más veces sean necesarios y luego quizás incluso buscar nuevas medidas para evitar el reservorio ambiental de estos microorganismos tan persistentes y supervivientes, incluso en situación de sequía, como es la Candidocima auris y la Acinetobacter baumani.
A ver, yo creo que nosotros hemos mejorado muchísimo desde el 2016, hemos mejorado en la identificación y en el ser oportunos a la hora de dar un resultado, pero siempre hay algo que mejorar. Ahora mismo tenemos muchísimas pruebas de diagnóstico molecular disponibles que agilizan la identificación. ¿Por qué? Porque esto también ayuda y alivia la carga clínica y también la carga de los familiares, que también es muy importante, porque un paciente que está aislado es un paciente que es poco visitado también por los familiares y eso también genera una carga emocional para las familias que tienen estos pacientes.
El principal consejo para evitar la diseminación de patógenos multiresistentes sería el lavado de manos. Fundamentalmente es la piedra angular del control.
Para mí la principal es la vigilancia activa, la vigilancia epidemiológica activa, según microorganismos, según tipo de hospital. Esto se debería implementar en todas las unidades críticas de todos los hospitales.
So we arrived at our next keynote speaker. We welcome Diamantis Plachouras. He's the head of the Antimicrobial Resistance and Healthcare Associated Infections section within the ECDC. Hello.
Hello, good afternoon.
The floor is yours, Diamantis.
Thank you so much. So after these both, I think, sobering and inspiring experiences from healthcare workers, let's see what the latest data on antimicrobial resistance and microbial consumption and healthcare-associated infections are telling us. So here at ECDC, we published the latest results on antimicrobial consumption in the European Union and on antimicrobial resistance on the occasion of the European Antibiotic Awareness Day on the 18th of November, as we do every year. And these results are publicly available on the ECDC website. So some of the key results from these reports are the indicators that we are using to monitor the progress of the European Union towards the EU targets for antimicrobial resistance and antimicrobial consumption that were established from the Council recommendation on stepping up EU actions to combat antimicrobial resistance in a One Health approach. And these targets were established in 2023 and are to be achieved by 2030. So the first target is a 15% decrease in the incidence of bloodstream infections with methicillin-resistant Staphylococcus aureus by 2030. And this is a spoiler. This is the only target that we are on track to achieve. As we see, currently the incidence is 20% lower than the incidence on the baseline year of 2019. So we are on track to achieve the target of 15% decrease. What the table on the right side shows us is that in the rightmost column, that although several countries have already achieved their target as shown in green color, there are many countries that had shown increases in the incidence of bloodstream infections with MRSA, as shown in red color. The second target is a 10% decrease in the incidence of bloodstream infections with third-generation cephalosporin-resistant E. coli, and these are very, very common infections. And what the data show is that although there was a decrease during the years of the pandemic, the incidence bounced back since then and is currently actually 6% higher than the 2019 baseline and is increasing. So this means that we are off track for reaching this target of 10% decrease by 2030. What the table on the right side shows is that in most of the countries, there have been increases in these incidents, and in only 4 countries have already achieved this target as shown with the green color. The third indicator, the third target, is a 5% decrease in the estimated incidence of bloodstream infections with carbapenem-resistant Klebsiella pneumoniae. And these infections are actually affecting hospitalized patients for the most part. They are healthcare associated, and they are very difficult to treat because carbapenems are last line antibiotics and there are very few alternative treatment options. And what the data show is that unfortunately there has been a continuous and actually ongoing increase in this incidence, so that currently the incidence is 60% higher than 2019. And this, of course, shows that we're moving to the opposite direction from the one needed to reach a target of 5% decrease. The table in the right shows 2 important things. First of all, in the second column, we see that there is a very large variability across the countries in the incidence, these ranging from almost 0 to more than 20 infections per 100,000 population, and this is a 1,000-fold difference. The table also shows that only 5 countries have had decreases in this incidence, while in the majority of countries there have been increases, and in some cases quite considerable ones. There are also 2 targets on antimicrobial consumption. The first one is a 20% reduction in the total consumption of antibiotics until 2030. And again, here what we see is that although during the years of the pandemic there was a decrease in the total consumption, this has bounced back, and we are currently, the consumption is currently 2% higher than the baseline of 2019, showing that we are again off track for reaching the target of 20% decrease by 2030. The table on the right side shows again that in many countries have had increases as shown in different shades of orange, while in only a few countries there have been decreases in the total consumption, and no country has yet achieved their individual recommended reduction targets. The second target on antimicrobial consumption, and this is very relevant to what we heard before about narrow spectrum antibiotics, is that at least 65% of the totally consumed antibiotics should be in the WHO aware classification access group of antibiotics. And these access group antibiotics are narrow spectrum antibiotics that are very effective for the majority of community-acquired infections, and they put a little selection pressure on bacteria to develop resistance. What we see here is that there has been very little progress in this respect, and actually in 2024, only 60% of the total antibiotics were in the access group, so even a bit lower than the baseline of 2019, which was about 61%. So the graph on the right side, which shows the access group antibiotics in the green color, we see that only 8 countries have achieved their target of 65%, while the majority of countries are below that. And in some countries, only around 40% of the total consumption is in the access group of antibiotics. So there is a lot of work to be done across the EU on this in this area. Recent data also showed us, and these data were published in September, and these data show us, for example, a rapid spread of this antimicrobial resistant fungus, Candidosima auris, in the European Union. And this is an emerging fungal infection. And from one case in 2014, we are now up to more than 1,300 cases in the EU in 2023. And in some countries, there have been several outbreaks and even an endemic situation. And this is important because this fungus causes infections, causes severe infections with high fatality rates among severely hospitalized patients. And also it causes difficult to control outbreaks in healthcare facilities. So the data show us that the EU is not yet on track to reach most of the targets on both antimicrobial consumption and antimicrobial resistance. On the one hand, consumption is increasing with little progress in the proportion of antibiotics from the access group, while on the other side, infections with carbapenem-resistant Klebsiella pneumonia and third-generation cephalosporin-resistant E. coli, and these are 2 pathogens of critical public health priority, continue to increase despite the targets for decreasing. What does this mean for patients and healthcare workers? First of all, an increasing lack of effective treatments for previously treatable infections. On the other hand, it means a higher burden of disease, disability, longer hospital stays, and risking, on all these risks, advances of modern medicine like cancer chemotherapy, intensive care, and organ transplantation. And finally, an emotional burden for patients, families, and healthcare workers, as we very clearly heard in the healthcare worker experiences previously. So everyone, healthcare workers, administrators, policymakers, patients, and the public, everyone among us has a role in ensuring appropriate antibiotic use and effective prevention of infections. Thank you.
Thank you very much, Diamantis. I'll see you in a few minutes. But right now, we welcome Shaida Said. She leads the Secretariat for the European Partnership on One Health, AMR, based at the Swedish Research Council in Stockholm. Hello, Dr. Said.
Hi there. Hi.
We are waiting for your presentation. Go ahead.
Great. I'm just going to do that. Okay. Thank you so much for the introduction and for the opportunity to speak at this event. That's really fantastic. I'm here really to present one of the solutions that the European Union has on tackling AMR. And it's the newly launched European Partnership on One Health AMR. And I'm specifically going to be speaking about the new research call that we have just launched actually on the 18th of November on the European Antibiotic Awareness Day, and which is now open. But just to give a little bit of background about the partnership. So like I said, we launched this year. We had a fantastic launch event in Brussels, which kind of sets set things off. And just to mention that it's the Swedish Research Council here in Stockholm that is coordinating the partnership. The partnership has 53 members as of now across 30 countries, mainly in Europe, but also beyond. Mainly our partners are national research funders, but we also have national ministries, research performing organizations, as well as some other international initiatives. And we have a common pot of 325 million euros, both for funding research and innovation projects, as well as implementing the actual program alongside other activities aside from the research that we fund. And this is an EU co-funded program, meaning we get 30% of our funding from the EU. So what is the program about? Well, so the main aim of the program is to tackle AMR using a full circle approach. It's a One Health approach, and we're envisaging a reduction of burden in AMR through this program. And that is by boosting One Health research and innovation in particular, making sure that we can generate evidence-based knowledge that will then lead to evidence-based products, practice, and policy. And just very quickly about the scope of the whole partnership. So we do have a functioning website. It's up and running since a few months now. So please do have a look there. We have our strategic research and innovation agenda, which essentially has provided the scope for the whole partnership. But more or less, we have identified 3 focus areas that the partnership is tackling. It's around the prevention of emergence and spread of AMR, around strengthening appropriate use of antimicrobials alongside with IPC, and then also innovation around cost-effective treatment options. And just to say, because I've been following the chat as well, just to say that we are taking a One Health approach, meaning that we're tackling AMR from the human health, animal health, plant health, as well as the environment health side of things. It's a challenge-driven approach, meaning that we identify areas that particularly need research and innovation, which of course coming to AMR is most. We work across sectors, we work across disciplines, and it's also worth mentioning, because we've been hearing this a lot in the videos, that we cover antibacterial resistance as well as antifungal resistance. And so coming to the main part of my presentation, which is the research call that we have just launched. So the first research call that we have, which we launched on the 18th of November, is around cost-effective treatment options. And the call title is Treatments and Adherence to Treatment Protocols, which I think many healthcare workers will find quite useful to be aware of. This is a project we will be giving project grants, I should say, and this is a 2-stage process, meaning that the first closure of the call for the pre-proposals is on the 2nd of February. And we have a total budget of just over 31 million euros for this. And you can see, so the partnerships have the point is that we are promoting transnational research consortium, transnational collaboration. So on the right-hand side of the slides, you can see all the participating countries in this research call. I have also flagged that please, if you are interested in applying for this call, do look at our website. All of the information, the specific information is there. And there are also some certain specific information attached to each of the countries that are participating. So the topics for this research call is around is on identification and development of new combination treatments, The second topic is around development of tools and methods to improve adherence to treatment protocols. And just to mention here, we have a mandatory engagement of end users here. And then topic 3 is around assessing the impact of antimicrobials for veterinary and agricultural use on the risk of AMR transmission to humans and the environment. And this is essentially to inform policy and make sure that we're taking policy is based on evidence. And again, you please do look at the website because it specifies in a lot more detail what these topics actually entail and some of the specifics that is related to each of the topics. But just to mention again that these topics do straddle both antibacterial resistance as well as antifungal resistance. And just to mention that one of the main aims of the partnership is of course, to promote transnational collaboration. We heard from Radu that collaboration is key, working together is key, and we think that too. So to be able to apply for our research calls, you have to form transnational research consortium. And there are specific criteria for how to form these. There are a maximum 6 project partners that can include, and each consortium has to include a minimum of 3 eligible partners from 3 different eligible countries to really kind of promote that transnational aspect. And I just wanted to flag that, of course, many researchers already work across countries, across borders, but we have also initiated a partner search tool, and I've put the link there, which is a great tool for finding partners or finding interesting projects that you may want to be part of. And I've also just put below the types of funding recipients that, or the types of recipients that can actually receive funding from us. So it's not only academics, as you see, but we are also funding enterprises, and others. Let's see here, clinician, public health sectors, as well as operational stakeholders. And just to flag a few of the important dates, as I mentioned, the call is already open. We were obviously hoping to make a big splash on the 18th of November when this webinar was originally planned for. But just to flag that we did actually go ahead with a webinar of our own for applicants, and we have a recording of that available on the website. So if you do have further questions or further sort of things that you're wondering about, I really encourage for you to look at the webinar. So the deadline for the pre-proposal is on the 2nd of February, and the deadline for the full proposals, the invited full proposals, is on the 17th of June. This is just a quick advertisement for the webinar. We had about 1,300 people signed up for it, so there's a great interest in this, so I do encourage you to have a look at that as well. And if you do have any further questions, you can always contact the call secretariat or the secretariat here at the Swedish Research Council. And that's me.
That sounds great, Shahida. Very many thanks. We have arrived at our second panel discussion, so I think, yes, Diamantis is coming to us. And I will remind our listeners and viewers that they can post their questions in the chat or the Q&A tool. Please do so, and I will try to get through all of them. The first one I want to post to Diamantis, it was posted by Gerard Colleran. How important are the drug-resistant microbes from the hospital environment to the overall antimicrobial resistance?
Yeah, thank you for this question. Environmental cleaning is key for infection prevention and control. And this is not relevant only for Candida or Candidosema auris, but also for many of the other bacteria that are causing healthcare-associated infections like Acinetobacter baumannii. And it is also known that many other bacteria that cause difficult to treat infections in patients are related to the environment, especially to water sources like sinks or bathrooms, toilets. And there has been a lot of effort to control these, but environmental cleaning is extremely important. And I would also like to flag another important factor that is often overlooked, and this is the cleaning and disinfection of medical equipment. There was a recent study from Australia that showed that enhanced cleaning of medical equipment that often is it's often used to for several patients and can be a source of transmission of pathogenic bacteria. So enhanced cleaning of medical equipment was associated with a very significant a decrease in the number of healthcare-associated infections.
Mm-hmm. It's probably a little bit further from our topic right now, but Mary McCarthy posted the question, what about the antibiotics used in animal husbandry? Does this affect, it must affect the antimicrobial resistance, doesn't it, Diamantis?
Well, we know it affects antimicrobial resistance. There is a lot of data on that. In Europe, fortunately, in the last decades, there has been a decrease in the use of antibiotics as growth factors that was very prominent previously. So our colleagues in the animal health and food safety sector have managed to decrease much more successfully than we have in the human health sector. Of course, there is again variability across the countries, and there are some countries where there is still quite considerable use of antibiotics in the animal health sector, but overall we have seen considerable decreases in this area.
Mm-hmm.
Can I just come in there?
Yes, please.
And it's a really important question, because that's why it's really important that we have initiatives like OHAMR, which actually does take that One Health approach, recognizing that it's all interlinked. The use of antibiotics in animals and the AMR rates in animals and absolutely affects human health. Through various transmission routes. And so, of course, it also impacts then what happens in the environment. So it's all interlinked. And so making sure that we are kind of taking that cross-sectoral approach to research, for instance, is incredibly important, so that we're making sure that the evidence that we are generating, the knowledge that we're generating through the research takes into account the different aspects which lead to resistance.
I wondered, we heard a lot about we have the old antibiotics, we have new antibiotics. We know that the development of new medicine is very cost effective. It takes a long time. And Mr. Papadimitriou in one of the videos said this arsenal we had against infections and microorganisms is being depleted. So what can we do? Like 2-3 concrete steps to refill this arsenal? Shahida.
Sure. I mean, it is really tricky, and the main reason it's really tricky is because there is no market incentive for producing antibiotics. Companies go bust even if they're successful in actually bringing a antibiotic to the market, which in and of itself is a challenge. They often go bust because there is no market incentive. So there's a lot of work being done on the pull side of things, let's say, to create essentially, and the EU is obviously part of this work as well. They're figuring out how to create pull incentives, so incentives to make sure that that innovation of new antibiotics can happen. So it's about changing the perspective of how you view the value of antibiotics, rather than it being dependent on the volume of antibiotics that you buy. Companies can be reimbursed based on the value of the antibiotic to the public health sector or to the kind of the health sector. So this is a very concrete step that is being taken, that has been taken in some countries more successfully, like in the UK. They have a very successful pilot model at the moment, and in other countries as well, following suit. But this also obviously then has to work hand in hand with the push funding, which is where we come in. We work at the sort of fundamental research, early stages of research level, and we need to make sure that there is enough research happening so that we can actually push research into the pipeline of new antibiotics.
Yes, please. I wanted to ask you.
I think we need also to keep in mind that even if we develop novel antibiotics, if we continue using them like we have been using antibiotics so far, we will very soon lose them. And we see it already with several antibiotics that have been recently approved. And what we see is that there is increasing resistance even to these antibiotics. So I think along with developing novel antibiotics, we need to make sure that we have efficient and effective antibiotic stewardship implementation in place to ensure that these antibiotics will not overused and misused like we have been doing with all the already available ones.
And doesn't that include talking to the patients in more detail and explaining to them that probably because they have a sore throat, they don't right now need an antibiotic, and explain the functioning of medicine in more detail? Diamantis?
Yes, this is key. Communication with the patient is key, and sometimes we heard also previously that doctors and nurses don't have sufficient time. So the easy solution is to prescribe something, but I think this is the wrong way to move forward. There is definitely a need for patient education, for the education of the population, also to increase awareness about the appropriate use of antibiotics. Antibiotic resistance is a bit like climate change. So if I take my car to work, I may think that my contribution is minimal, but if everyone does this, then we end up with the problems we see and a lot of traffic. So antibiotics is the same. If everybody uses them, everyone individually may feel that, okay, it's very little contribution, but eventually we end up with having no antibiotics available.
Mm-hmm. We have a question from our viewers. It's dedicated to Diamantis. Deployment of appropriate cleaning and disinfection processes in the built environment of the hospital may do much to diminish and control the menace posed by Candida auris. Is there a risk that we will see also an increased resistance to traditional disinfectants?
That's a good question that has been discussed a lot. We haven't seen a lot of resistance to disinfectants or other biocides, but it is definitely a threat and a risk that we should be monitoring very closely.
Okay. Zaida, could you talk a little bit more of what you think the proposals that are coming in will deal with or will have to deal with from the call you issued on the 18th of November?
That's a very tricky question because researchers are very inventive. I think, we have our 3 topic areas. We've given guidance. Obviously, it's around combination treatments. It's around improving treatment protocols. and then it's around sort of understanding the risk of transmission. We've had the webinar actually includes a lot of kind of questions around, would this idea be okay? Is this a useful idea? Could we apply with this idea? And it's sort of all kinds of ideas under the sun. So it's a bit of a tricky question. I think, I will let the 3 topic areas speak for themselves. But I can also I can just also say that we are very excited about this. We're really keen to see that there's been a lot of engagement. We also know that the research community has really looked forward to hearing kind of news from the partnership as we've just gotten started. But just to also say that we are trying to, and there is a lot of figuring out. We don't have the answers yet. We are a partnership on One Health. We know we need to work cross-sectorally, and we know we need to work cross-disciplinary. Exactly how, we are still figuring these things out. But one of the kind of important aspects of our partnership is that we need to make sure that the research that is being funded through the partnership actually is useful, that it doesn't just end up on the shelf of the lab and then that's it. We need to make sure that it generates the impact it's needed. So we have a huge push in the partnership to engage end users and stakeholders, everything from people who would use the innovations that are coming out or the research that is coming out from the partnership, including healthcare workers. We are establishing governance structures that would allow end users to formally associate themselves with the partnership, but we're also encouraging, and in some of the topics, as you saw, it's actually mandatory that we have end user engagement. So it's really making sure that the research that we're funding is also relevant for the community.
Thank you very much. We move on to our next scheduled point. We have all of our keynote speakers on screen, except of Radu, who had to leave earlier, but that's fine. And how will this work? I will pose the same question to every one of you, and I asked you to stay roughly within 1 minute with your answer. And I will start with Massar. What are the key aspects? What is the main message you take away from today to help us moving forward?
Yes, thank you all so much. And it was lovely to hear everyone's presentations as well. I think a lot of elements that have been touched upon about the importance of the different factors for infection prevention control, such as protective equipment, hand hygiene, etc., as well as the different influences of behavior, such as staff not having enough time, and again overprescribing and the judicious use of prescribing of antibiotics. And I think from a behavioral lens, it's really important to think of beyond just providing education and thinking about why do people, these are all forms of human behavior. So why are people not performing the behaviors, even if they do know what they are, for example? So kind of taking that step back, thinking about how we can develop intervention strategies to understand why people are not performing these behaviors, and how we can target those influences. And that requires a lot of collaborations with other behavioral scientists, but as well on an interdisciplinary collaboration with other stakeholders to be able to target these. So I think this is where to think about a bit more from a behavioral lens.
Okay, thank you very much. Péter, as you were in the first keynote session, I will move to you. What are your key aspects, or what is your main message you take away from today?
Yeah, thank you. So we are here from many countries, and the audience, I could see a lot of countries indicated. And I think there are clear differences, not only between EU countries, but also within them, where good and less effective practices often coexist. But this shows that stronger collaboration among healthcare stakeholders still has room to grow. For example, cross-sectional cooperation between doctors, veterinarians, dentists, pharmacists, and other professionals, following the One Health approach we also mentioned. So this can help make our system more resilient. But I would like to close with the opinion that a safer, healthier future requires coordinated, well-monitored guidelines, as well as adequate attention from decision makers and allocated financial resources. Thank you for the possibility.
Thank you, Peter. Zahida, I move to you. Your key aspects, your main message you take away from today, from everything we heard from the keynote speakers we saw in the videos.
Sure. I'm almost going to repeat, I think, what Peter just said. I really take away the working together and the collaboration aspect, how important it is, for a partnership like us focusing on research to hear from the community, to hear from the different sectors and disciplines to inform better prioritization of research and more impact from the research that we do. And I just kind of wanted to mention this as well, just to demonstrate, I guess, that research really does form a pillar or a cornerstone in our fight against AMR. We are 6 days away from the 80th celebration of when Fleming received his Nobel Prize for the discovery of penicillin. So, and which of course we all have greatly benefited from in time. So just wanted to kind of make the point that now, as we're in this era of penicillin and antimicrobial resistance, really working together is key.
Thank you very much. Diamantis, what are your key aspects you take away from today, the main message?
Thank you. So I think the key message from today is that, first of all, implementation is the most important factor that we need to focus on to make things really happen, to make things change. And this is a collective action. And what I mean by this is that we know what needs to be done. And we have very good data. We need to use this data to drive our actions. But the actions need to be at many levels. So we need policies that will promote appropriate use of antibiotics and also strengthen infection prevention and control, removing barriers and providing incentives. We need also not only policies, but we also need the research to remove some of the barriers. For example, a very good example of that is the lack of point-of-care diagnostics that would really solve many problems. So we need research for novel and innovative diagnostics that the prescribers can use to help them make the right decision. But we also need individual effort to change. And because this is also in the hands of everyone. So everyone has to play a role in ensuring both appropriate antibiotic use and less and better prevention of infections. And this can be not only the pressing for antibiotics, for example, but also vaccination. We shouldn't forget vaccination and the importance of vaccination, because many of the infections that antibiotics are used for are viral infections that can be prevented by vaccination, like influenza, for example. So I think let's take them as a main message that it is a collective responsibility.
Thank you very much, Diamantis. Well, we are nearing the end of this EAAD event. I hope all of you keynote speakers, all of you viewers at home can take some information and motivation back to your workplace. let's not forget to summarize what we all just heard. We all have a responsibility to use antimicrobials prudently, both patients and the public at large. So I'm not an expert, I'm just a journalist, but I will talk to my general practitioner the next time as well, when she probably suggests using antibiotics if I really need them. As we are all potential users of antimicrobials at some point in our lives, if we contract an infection, it is vital to retain the ability to treat these infections. So, if you are looking for resources and information about antimicrobial resistance as well as infection prevention and control, you can head to the ECDC website, antibiotic.ecdc.europe.eu. We will put the link also in the chat for you to copy. This leaves me to say thank you. Thank you to our keynote speakers again for their insights, and thank you for watching, listening, and participating with your questions. Have a lovely afternoon and keep washing your hands. Thank you. Bye-bye.